Good morning, everyone. Thank you so much for joining us. Thank you for being part of Becker's annual meeting day 2. I am Molly Gamble with Becker's, just delighted to kick off the day with our next panel, Growth Strategies and Investments for the Future of Surgery. We are going to be catching up with thought leaders from Sharp Healthcare in this session. This is a featured session made possible by our supporter, Intuitive. The Sharp team today will cover a lot of ground. Their growth strategy around surgery within their system, investments they are making toward realizing that strategy, the results they've seen so far, and also a lot of time spent on what's to come, a very forward-looking discussion. Let me turn it over to our panelists at this time and lend them a moment to introduce themselves, greet you, and share more about their roles within Sharp, just so you can best appreciate their point of view today. Chris, you're to my immediate right. I'll turn to you first.
All right, thanks, Molly. Good morning, everyone. My name is Chris Walker. I'm the Chief Operating Officer at Sharp Memorial Hospital. Really appreciate you all being here this morning, and really appreciate Becker's invitation to speak with you today. A little bit about Sharp. So we come from Sharp Memorial Hospital, which is the flagship hospital for Sharp Healthcare. Sharp Healthcare is I call it a small integrated network of 4 acute hospitals and 3 specialty hospitals. With those hospitals, we have about $4.5 billion in annual revenue, and we do about almost 60,000 surgical procedures per year in those hospitals. I'll kick it over to Dr. Lee here.
Hi, good morning. I'm Dr. Pamela Lee. I'm a colorectal and general surgeon at Sharp Memorial. I'm a Da Vinci total practice surgeon, so pretty much all of my cases are done robotically currently.
Thanks, Dr. Lee. Good morning, everyone. Tony Guerra. I, like Chris, have spent my entire career at Sharp Healthcare. I've served stints in 2 of the other hospital campuses, and I've been on the Sharp campus where Memorial is for almost 10 years now. So I've been the CFO for about half that time. I've been in several different roles throughout the organization, and more recently, with some of the restructuring that has happened at Sharp and on our campus, I've taken on more of a role over growth and strategy in addition to my CFO responsibilities. So along with Chris and Pam, getting to do a lot of fun and interesting things with all the challenges that we're facing today.
More than about 60 years of collective experience with Sharp at the podium today. Really remarkable longevity in healthcare with one organization. So panelists, at Sharp, I know that you are constantly looking to find ways to stay ahead. We just came off of a keynote panel about leading in lean times, the financial challenges that health systems are confronting, also a lot of attention paid to workforce. How does your surgical program connect back to these big organizational goals and strategies? Dr. Lee, can I turn to you first?
Yeah, so just to give you an idea about the landscape, I joined Sharp in 2015. I trained as a robotic surgeon and fully committed to the technology in about 2017. During that time, there was a lot of mistrust of Intuitive, and from the surgeon standpoint, we really didn't have access to the tools that we really needed and wanted to provide excellent healthcare to our patients. So the landscape at that time was not great from the surgical perspective, from the practitioner perspective. So over that time, over from 2017 basically to today, the evolution that we've made at Sharp has been remarkable. For us, the guiding light really has been the quintuple aim, and that's something that I think all of us agree on up here on the stage, which is equality of access for our patients. It really shouldn't matter what time of the day or what insurance or what hospital you come into at Sharp. You should be offered the same minimally invasive surgery.
Chris, I'm just going to add on a little bit there.
Go ahead.
Yeah. So Sharp, like all of you, have a vision to be, we want to be the best place to work, practice medicine, receive care, and certainly we can see where that aligns with the quintuple aim. When we started thinking about strategy, though, me and Tony both came into our role right at the same time in 2019. And we came into a place where we had to assess, what was the current landscape. And as Dr. Lee said, it wasn't really that great. And we didn't have data. We didn't really understand the surgical business very well. We knew that we made pretty good margins on a lot of surgical cases, but we didn't understand why and where there was opportunity. And part of that assessment when I came back was that I had a lot of frustrated surgeons. So one of the big turning points for us as an organization was we had a lot of physicians that were retiring, and we had all these new physicians that were coming in that were well-trained robotic surgeons with no access to robotic technology. And so we had this, I'd say a groundswell, but it was more of a tidal wave of frustration. And I came into my COO role, I had a line out the door telling me all the things we're doing wrong as an organization and the lack of alignment between the C-suite and our surgeons. And then when I assessed the landscape, I realized that I kind of agreed with them, that we had all this surgical talent, and we were telling them, hey, I know you're a fellowship-trained robotic surgeon, but I'd like you to do your case open. I'd like you to do your case on a laparoscopic tower that was dated. And then we had robots, we had a couple robots that were, burning 24/7 for the people trying to get access. Or worse, it was leading to long lengths of stay because people would wait several days to get on the robot to do a case. So we had a lot of frustration. We certainly wasn't the best place to practice medicine. It wasn't the best place to receive care either, because patients were either having long lengths of stay waiting for cases or being forced to have a case that was going to lead to a long length of stay. So we knew that we really had we had an opportunity to reframe where we're going strategically.
Tony, we're talking about this 2017, 2019 timeframe. I appreciate the candor of where things were. Anything you would add to what your colleagues have said so far, the picture they've painted?
Yeah, excuse me. I would think what I would add is Chris touched on the alignment piece, and I think that admittedly there was some misalignment among the C-suite as well. And the CFO who I succeeded is by far one of the most dynamic, incredible CFOs I've ever worked for. She was my first boss and my mentor. But I think admittedly she was also looking at the picture from a financial standpoint from a very focused vision on cost only. And I think one of the important things that changed was looking at the bigger picture, looking at the broader picture, and obviously aligning with Chris and with our C-suite and with our surgical staff was critical. And I think another point that I'll probably weave in almost every question is just the composition of our organization, really looking at the value-based model is critical. We're an organization, especially in our hospitals, as an organization in total, with a very highly capitated structure. And especially on our campus, our inpatient services are nearly 40% capitated. So yes, it's important, it's critical to look at the cost picture because of that model of capitation. But to be successful, to look strategically into the future, it can't be just on that one financial cost picture. It has to be the entire picture that incorporates cost, quality, et cetera.
I think a really rich picture, hopefully for everyone, about where Sharp was. And this wasn't, what strikes me is this wasn't all that long ago, 2017, 2019. Let's look ahead. You found that your Da Vinci surgery program is not an extracurricular. It's really the cornerstone of strategy. Let's walk through some key milestones that you've been able to achieve and now point to in the years that have elapsed since the picture you painted of where you were. Can you share some of those with us? Tony, I'm going to go to you first here as the CFO. What are some key accomplishments or achievements you would point to?
Well, I think the slide that's up on the screen obviously paints a very impressive picture of where we've gone as an organization. And again, much of my direct knowledge that I'll speak to relates to our campus at Sharp Memorial and Sharp Mary Birch. But obviously, we were the first movers and the leaders in the organization to really kickstart our robotic growth. Going back to that time frame that we were referencing in 2019, I think that was an important milestone because we realized that access and the changing landscape was really important to acknowledge and to reframe our focus. I think that looking from that point forward, I was thinking about the fact that we were probably very fortunate that we got ourselves aligned and on track pre-pandemic, because everything that affected our industry and our hospitals during the pandemic, and then obviously for the few years afterward, really could have made it really would have set us behind, I would think, in terms of being able to execute on the strategy and the growth. And so I think the other important part of one of those other important milestones is looking at what I referenced earlier, which was really reframing the evaluation of the financial picture. And so I really worked with my team and completely reevaluated the acquisition models and what made the most sense from the standpoint of acquiring the assets that, as you can see, obviously took off because of the flexible acquisition models that we were able to evaluate and evaluate differently than how my predecessor looked. So I'll stop there because that kind of is an important contribution that I think I brought from a financial standpoint working with our C-suite.
Dr. Lee, key milestones you would point to?
Well, I mean, I would just say the evolution over, that time period from 2017 till the present day now is, I say this in some of our talks that I almost can't recognize the Sharp that I'm in now because it was such a struggle back then in 2017. It was really a lot of mistrust and kind of resentment on the part of the surgeons to the administration. It was really not a great place for us to work at that time just because we didn't feel like we were supported by the administration or the hospital. So I would say the milestone for me that is really amazing is just feeling supported in my institution and feeling like we're all rowing in the same direction. It goes from the C-suite all the way down to the people that are helping in the operating rooms. It's a general, it sounds kind of cheesy, but just kind of a general good feeling that everybody has, that we're all on the same team. And to feel supported from the surgeon perspective in that way is something I haven't experienced in other hospitals that I've worked at, so.
And I would just add, so we went from being a place where there was no access, and that was what the lineup at my door was all about access. And I know we no longer have that. That's like we're past that conversation. And I know many executives in the room probably have to deal with that question many days or most days. Like, I can't get access. I want more access, whether it's block or robot access. It's a constant conversation. And we've kind of eliminated that noise from the conversation. And now we're focused on things that are more important. So over that time, we went from really 2 or 3 specialties having access to the robot to having, now we just hit our 10th specialty using robotic technology. We went from a few robots to 14 in our hospital so that we can deliver really the best possible care to our patients. And then over that time, we went from having no data to drive our decisions to having even more data than we thought we would ever have. And I think that was critical for us, was that we could then start to use data to validate value propositions that we were trying to try to really make a philosophical argument about why is robotic technology better. And really over those few years, we've really pretty close to eliminating open surgery in cases that could be done minimally invasive. And that was really one of our guideposts for where are we going. And we knew that open surgery had more complications, cost us more over time because of length of stay and labor costs, and we needed to find ways to improve.
Chris, I'll stay with you a moment because in that last graph we saw, you saw the bar graph, and I love bar graphs because they look so simple, and behind that is so much decision making. But 2017, the robotic fleet was 3, 2018, 4, 2019, 5, 2020, 9. 2021, 14. So you see all of a sudden it looks like there was this really big year where something shifted. And you talked about having more data than you thought you could have. What were some key data points that really validated your decision to make further investments here? Can you point to some of those things that kind of was part of that landmark shift when you started to really ramp things up?
Yeah, I think on the previous slide there was, length of stay was the best first measure for cost and quality. So we were tracking length of stay. It was something we could easily track right away. But then we started to be able to look at all of our cases by, surgical site infections, complications, return to OR, readmissions, blood utilization, all those data points, all of those equal cost and quality. And so we really started to measure all of those and start to look at the differences between our open, our laparoscopic, and our robotic technology. And we proved over and over in many different specialties the value of the robotic technology and how that actually helped us lower the total cost of care. Sharp Memorial, or San Diego in total, is a very capitated market, and we take risk on a fair number of our patients that we care for. And I'd say double down, but we probably like quadrupled down the investment in robotic technology because we know that it drives our costs down. And it drives our costs down because it drives quality in the right direction. So better quality care costs less. That is what we've proven, that's what we believe, and that's what we're supporting. You can see here, like robotic technology started to overlap the laparoscopic and the open procedures in about 2019, and then it's been really significantly increased. So anything that can be done robotically, we have over 60% now being done on a robotic. And so we have, like I said, we have 39 ORs on our campus, and we have 14 robots. So we're almost up to half of our ORs probably by the end of the next year or so.
Thank you, Chris. And Dr. Lee, you've pointed to a lot of the cultural change behind this program and the shifts at Sharp. What are some data points that really you have caught your eye or surprised you even throughout this transformation?
So I will say this, and Chris and Tony can agree with me, I'm sure we've talked about it for a long time, that the data piece for us has always been the hardest piece. And I think in speaking to other health systems and doing talks sometimes, that seems to be kind of the elusive factor, is the data piece, because we always say garbage in, garbage out, right? If you don't have the right data, you're not going to get the right answers. So I think that once we finally did get the data, and it took a long time for us to clean it up, it reinforced what I think most practitioners that use the robot see. That was part of the problem, and Tony kind of talked about it, looking at one silo rather than the total cost of care. When I was doing robotic colectomies, I knew that my patients were going home sooner. I knew that they had less, complications. I knew they had less pain. They were going home on Tylenol and Motrin versus, a prescription for Norco, like I was doing with my laparoscopic procedures. So the data, ended up, basically panning out exactly in the direction that we thought. But until we actually had that data, we could talk about it all day, but it was just anecdotal from a surgeon perspective. But I will say that was the hardest piece for us to get.
Mm-hmm. Mm-hmm. Tony, what's
Yeah, I think one of the case types that you referenced is one of the ones that I was going to touch on. And just to kind of put into perspective, when I looked at some of our recent data from actually over a number of years, so a pretty good sample size, I think it was our, our colon resections for our inpatient, or maybe it was our small bowel resections. Anyways, almost a 50% decrease in inpatient length of stay from open versus robotic. So right there, I mean, the data speaks for itself. And again, especially with a pretty high percentage of patients who walk in our doors under a prepaid insurance model, the cost picture is critical. But then I think another case type, looking at cholecystectomies, what I was mentioning earlier with Chris was that when we look at those cases, the financials actually look somewhat similar from a total cost per case. And so to me then, I would go to Pam and Chris and say, that's great, from a financial perspective, those cholecystectomies look fairly on par in total. But then what about the clinical outcomes? What about the readmissions? What about all of those other really critical total picture of the total care that matters to us, that really matters to the patient, that matters to our insurers, that matters to all the stakeholders that come into the picture when you're talking about healthcare these days.
Chris, is there anything you want to add there? I think it's a great point, Tony, that a financial metric can have very different clinical repercussions and vice versa. Is there anything you can share about collaboration among your leadership team to really make sure that you're getting, like Tony said, the rich and full picture of what this data really suggests and means?
I mean, I think what we were able to do is change the philosophical view of all of Sharp Healthcare leadership. We took that data, we built an executive committee at the system level, and once we started bringing that data back, I think there was no more. Our 2019 philosophy was no new robots. That was like, it might have even been in writing on the strategic plan, no new robots, you know, like, and now not only that is how do we grow that? And you know, that's translated into so much. We've become the first network of excellence. We have six of our ORs are accredited as robotic centers of excellence, and we're the first network of excellence on the West Coast. And it is our philosophy that we embrace that technology because we know it is about better care. And all of the executives across Sharp Healthcare believe that now. And that is part of what we thought might have been true based on what we were hearing from other surgeons, but being able to show that and be able to say that this is helping us deliver better care to patients, and hopefully this is going to help us deliver more care, a more efficient care to more San Diegans, and that's really what we set out to do. We're a community hospital, nonprofit community hospital that is committed to our community and delivering the best care we can, and we have to do it at the lowest costs with the best outcomes to pencil out our margins, and we've been able to show that this helps us.
Dr. Lee, what was the quote you said about surgery at any time of day? Can you repeat that again?
Yeah, I mean, kind of the North Star for me is, I always ask myself, if I were to have this done, how would I want it done? And so, for me, I mean, it's the answer is very easy because I see it in my practice every day, which is robotically. So the quintuple aim for me, and Chris mentions this too in some of his talks, is really just the equality of access. It seems, if you were to ask somebody on the street, like, do you think it matters what time of the day you go to the hospital, what insurance you have, and where you go, that it would change what procedure you get, the approach? Most people would say, no, it shouldn't matter, right? It should be the same wherever you go, or, but that is not true in most institutions. So a big part of our push at Sharp was basically unfettered access, 24/7 access to the robot. I'm a colorectal surgeon, but I also do acute care surgery for my group. So I'm doing gallbladders and incarcerated hernias and appendectomies. And so for me, I wanted to be able to utilize that technology at any time of the day. So you can see here, this slide is somewhat depressing for me, but also a testament to the access that we have. So fourth quarter in 2023, I did 35% of my cases on the weekends or after hours. And really that number to me just shows the coordination between administration, operations, and the clinicians. That is a team effort that allows those patients to be operated on weekends and after hours and still get the robotic approach.
And I think most people look at this slide and go like, why would you want to do after hours and weekends? Like, that sounds terrible, right? But what that really translates into is significant shorter lengths of stay. Because if they didn't do it afternoon or weekend, it's waiting till Monday, or it's waiting till tonight sometime. And one, there's a delay of care that could have potential quality implications. But there's also just the cost of that extended length of stay. So when her numbers go up on acute general surgery and 24/7 access, it's allowing the case to be done when the patient needs it, and not wait for a time when we have the preferred surgical tool. So having the preferred surgical tool when the patient needs it, it was critical to our strategy.
Tony, anything you would add when
Yeah.
looking at this slide?
I think the additional comment I would make is that we have been very intentional about making all of the necessary and appropriate investments to be the most efficient provider. And again, going back to the pandemic, one of the investments we made was in our wages. So why would I bring that up here? Well, because we went from having an extraordinarily insane cost structure of traveler nurses during the pandemic, like probably everyone else in this room did who operates a hospital, to I think our expense for traveler nurses last month was $275,000. So why do I bring that up? Because staff retention is critical. That includes the staff in the OR who is retained and skilled and competent, and the individuals that Pam trusts in the operating room. We've made the necessary investments in the technologies. As you all know, capital funds are incredibly scarce. If there's someone out there who does not have a scarcity of capital funding, let me know. That's amazing. So we've made the necessary and appropriate investments in our technologies, like our Da Vinci robots and the flexible acquisition models. All of these things, and in the prior slide talking about the after-hour surgeries, we are a 100,000 visit per year ER and trauma center, so these patients are continuously increasing in volumes and when they're coming in and when they need care. Those all help us with efficiency and throughput in the entire continuum. So that was one additional point that I wanted to add into that.
And Chris, you had said we are now past the point of questions about access. And when we saw the after hours weekend slide, I mean, and Dr. Lee, you're welcome to opine here too, but any shifts in surgeon attitudes, morale, feedback, things you've heard as that access has really opened up?
Yeah, it was actually kind of funny. Like, we tried to have a robotic steering committee in 2019, and I couldn't get anyone to show up. Because they basically said, if you don't fix access, we're not going to show up and talk about anything else. So once we fixed access, I said, okay, now we got to talk about quality, efficiency, teamwork, working together, and then elevating our programs together. So I think that was critical, that we eliminated the access question so that we could really focus on the things that mattered. And I think the morale of the surgeons, like, it couldn't be better. The relationship between the C-suite and the surgeons has been 180 degree, wouldn't describe it enough. I mean, it was transformational, to say the least, and how we work together. And it's really helped me build close ties and then be able to get to the hard conversations about how can each of the physicians get their data, and how can they learn from their data to improve? Can they standardize around the way they use instrumentation so that they can help bring their individual cost per case down? Can they learn from a more expert surgeon on reviewing a case so that they can translate that into learning and actually in being a better surgeon? And now with the ability to review their own cases, either through Intuitive has a hub, which allows them to get video access, where they can see their video and see where they have opportunities and see if they're hitting the critical milestones. So we've never had tools that allowed physicians to actually evaluate and course correct. It was always like, peer review. Anyone understands, you guys all understand the peer review process. It does not improve care. But now we're creating the tools that allow physicians to get better. They have their data. They have how they sit compared to others. We can identify top-performing docs that can mentor docs that need help and need to learn from those docs. So it's really changing the dynamics for how do we advance surgical care and how we actually advance the quality of care we deliver to our patients.
Mm-hmm. Dr. Lee, I said we would spend an ample portion of time on looking ahead on what's to come. And Dr. Lee, I'll turn to you first here, but we've seen the growth so far. We've seen the optimization about the minimally invasive surgery program. We've seen the cultural change, as you all have so candidly illustrated for us. Where do you see things going from here? What's ahead? What can you point to?
I mean, I will kind of jump on what Chris said, which is, we were lucky enough to be able to do one of the first cases on the DV5, which is the next-gen technology, and we're one of the few sites in the country that got the new DV5. So I did a colectomy like 10 days ago on it, and I think that this new robot, I think, number one, the ability for me as a surgeon to have more autonomy in the operating room, so pretty much everything on the robot can be controlled from the heads-up display inside the surgeon console, which you see on the left side of the slide there. It's going to be more efficient. The bedside assists, I did some cases last Saturday when I was on call, and we basically had people train that morning on how to use it, and the bedside assists were just amazed at how easy it was to use. So I think it's going to equalize out. I mean, all of us that are surgeons know that, you know, we always make jokes. You got the C team at like 9 o'clock at night, you know, doing your cases, but, you know, it's better than nothing. But for us to be able to equalize that skill set and, you know, have somebody be able to, you know, be an efficient bedside assist quickly, the learning curve, you know, get through it quickly is going to be more efficient for us in the operating room, less frustration from the surgeon standpoint. So yeah, and I think bringing in more robots, we've talked about access, but ultimately, you know, I do a lot of the hiring for our group in terms of, you know, for the new surgeons. And, you know, in talking to people that interview, they really don't want to be at a place that doesn't have access. So, you know, from the standpoint of hiring people that you're going to bring on into your community, into your hospital, I think it's incredibly important to think into the future, because these people that are coming out of fellowship, they don't want to go to a place that doesn't have access. So you're not going to be getting the best and the brightest if you don't provide that tool for them. So, you know, right now, there's a generation of skilled laparoscopists that I would say are probably in their mid to late 50s that are very good laparoscopic surgeons, and they are doing, you know, good laparoscopic surgery. But those people are eventually going to retire, and laparoscopy is, I mean, it is a dying art form. It's like the transition from open to laparoscopic. So if you want to, you know, really recruit the best and the brightest, I think that you have to think forward and provide the access for those people.
And Dr. Lee, just to follow up there, when you're meeting and interviewing and recruiting surgeons, is there anything beyond an access? I mean, I understand the importance of that, but is there anything even beyond the point of access or concern about access around the MIS program that can weigh their decision of how they see Sharp and their interest in working there?
Yeah, I mean, we hired a surgeon about 2 years ago who was basically a total practice robotic surgeon. And, you know, he had interviewed in other locations in Southern California. And once, you know, to the credit of the people that he spoke to, they said, our robotic access is not good. You know, you're going to have to fight for time on the robot. You're probably not going to get block time for at least 6 months to a year. And he immediately eliminated those places from his list. So when he came to Sharp 2 years ago, I was proud to say that we had access, that he would be able to get onto the robot in the outpatient setting, do flip rooms there with two robots, the ability to do 7 to 8, you know, hernias, gallbladders in a day and be out by 2:30 p.m. So for him, that was a big draw. So that's just one example of somebody coming to Sharp because of the environment that we provided.
Thank you. Chris and Tony, what can you tell us about the future as you see it, your plans?
Yeah, I think, so you've seen, if you haven't seen the Da Vinci 5 outside, you should take a look. And for most executives, you know, you see another shiny instrument that might, you know, have surgeons lining up at your door. But what we see is something that's going to kind of revolutionize the way the OR looks in the future. And we're already planning for having a robotic corridor. We're building 6 new ORs that will be all Da Vinci 5 robotic platforms. And part of that is because you don't have to duplicate the laparoscopic towers in those rooms. You can really streamline a lot of the equipment that's all now built in. So there's a lot of capital cost advantages to the Da Vinci 5. But what I like most about it is a lot of the technology that went into the surgeon experience. And you know, there's one thing to make surgeons happy because they can have access, but to allow them to practice in a way that, with just the ergonomics of the new console. I already see surgeons that were on the verge of retirement saying, I think I might be able to go a couple more years. I don't want to, turning over your 30-year veteran surgeons is a major hit to your organization. And if they can practice robotically and extend that expertise and be able to use the Da Vinci robot as its primary tool, and the design of that allows them to go longer, then that's a huge value for the organization to have that expertise. Not only is it a draw for the younger surgeons from a recruitment standpoint, but really helping our surgeons that really want to extend their careers is really one of the big pieces. But I think when you start thinking about a robotic program, how it crosses multiple service lines, like just the streamlining of how we educate our staff, how do we set up our rooms, it's just going to lead to more efficiencies. And I see a lot of the technology advancements have really took more than just the surgeon's perspective. They took the team's perspective into consideration, and they also take the executive's consideration into that with regards to how do we reduce the costs of a standard OR setup by having very streamlined systems that can do everything that we need. And I think that's what they have achieved, and that's why we're very excited.
Dr. Lee, I love how Chris is like, you're amping your achievements up. That's great. Chris, I'm really glad you brought that up about older surgeons, the ergonomics supporting their ability to stay in practice longer as they're weighing decisions about retirement, a really important factor to discuss. Tony, you heard reducing the cost. That was your cue. What can you share about the future to come from the CFO perspective with Sharp's program?
Yeah, I think Chris, just to segue on Chris's last point, we do a very good job of standardizing in our different clinical settings, including our ORs, but I think the key point that Chris touched on is what can we do to streamline? And so for those 6 new operating rooms that will be coming online in the next 2 years, these are the types of opportunities that I'm excited about and looking at, because incrementally, I think there's a lot of opportunity to preserve our cash, which is vital. This is all part of about a $1 billion campus redevelopment that is currently underway at Sharp Memorial and Sharp Mary Birch. And so the timing for all of this really aligns well with the decisions we're making. We already have much of the project designed, but now we're moving into the phase of what are the equipment decisions that we need to lock in. So having the opportunity to look at the new platform and look at what can be streamlined in these operating rooms is really crucial. And then I think it also then touches on, from my role and our executive team's charge, is really market share growth. Because in a market like ours in San Diego, which might be pretty similar across the country, we're looking at the reality of the demographics that are shifting. And we're in a highly concentrated market, highly competitive market. And so we can't reduce cost and cut our way to financial sustainability and long-term viability. We're a very healthy organization, fortunately, but we see margins just continuing to erode and decline. And so looking at making that leap to a growth strategy, this all ties in perfectly with where we're going, because we do believe that this is an area where we can capture more of that discretionary business in our marketplace that is non-capitated, where patients have a choice. So looking at the huge redevelopment on our campus, looking at these really important investments, and looking at the value proposition that we can make, again, to every one of our stakeholders, our patients, our insurers, our physicians, our community. I'm really excited about where we are and the hard work we've done as an organization to get us to this point for what's coming over the next 5 to 10 years.
Tony, Dr. Lee, Chris, I want to thank you so much for sharing this transformative story with us at Becker's today, and thank you too for your transformative thinking and leadership behind this work. Attendees, please join me in thanking our panelists. Thank you too for your attention today. Appreciate it.